Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clarnet, serving as the allocated session assistant to ensure a seamless experience. Clarnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarnet serves as a director partner for this event, and the focus of today's session is simulation. Now, I would like to invite Dr.AL.Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former National Vice President of the Indian Society of Anesthesiologists and has held key positions including Governing Council member, President, and State Secretary of the ISA Tamil Nadu Stage Brand. Now, without further any delay, sir, over to you. Thank you.
Thank you, Clearnut. Respected faculty and delegates. The 46th webinar of Puthukkottai Bhudhan Second edition. This is 47th. The 46th webinar of Puthukkottai Bhudhan Second edition was held on 3rd December under the theme Medical Legal Session. So the faculty were postgraduate, because in our webinar postgraduate is compulsory because they are going to be the future teachers. She is Dr. Rutucha Mahadev Ekatpure from Pune, delivered a lecture on informed consent, and Dr. Prathipa Kane from Jahangir Hospital, Pune. Madam has talked about decoding the documentation, and Dr. S. N. Krishnamurthy from Tamil Nadu. He has delivered a lecture on professional negligence. All the three are university questions for postgraduates, and the session was moderated by Dr. Shivakumar F. Kumbar from Dharwad, Karnataka. 879 people attended the lecture, and I wanted to inform, last time also 2 male and 2 female doctors participated. This time also 2 male and 2 female are participating, because usually in Puthukkottai Bhudhan, lady doctors are dominating the scene. Most of the time, all male only once came. All the other things are lady doctors are dominating. That means anesthesiology is dominated by lady doctors. It is a welcoming change. Now in the 47th webinar titled Simulation, which is very, very important. It is a essay question in due course. I think even Viva's practical exams will be held under a simulation only. So the simulation, the Yenepoya Medical College, Mangalore, doctors are participating as faculty, and Yenepoya Medical College is having a state-of-art dedicated simulation lab. So Puthukkottai Bhudhan is very choosy in selecting the speakers, and we are happy to welcome all the 4 speakers. And the youngest will be Yumna Aboobacker. So she is from Kerala. Even though she is studying in Yenepoya, Karnataka, she is from Kerala. I want to stress why I am stressing. I will inform later. She is from Kerala, and she has done her MBBS from Kannur, and she is doing her MD anesthesiology here. And this young lady doctor is interested in reading. Reading means I don't think that it is anesthesia. It may be some story or some other book than anesthesia, because people will not be interested in reading anesthesia text. And she's interested in painting. I don't know what painting means. During Pongal and festive seasons, they will paint the house. Whether it is that painting or artistic painting, I don't know, but she's interested in painting, and she's interested in cycling also. So why I am saying all these things, this young lady doctor yet to get married. So sometimes Puthukkottai Bhudhan will act as a matrimonial column for the postgraduates. So minimum 900 people will be seeing this program. So I want to inform that madam is a eligible bachelor. Thank you. I welcome you, and it will be followed by Dr. Vinayak. Actually, Dr. Vinayak Nayak arranged this program, because I contacted him some 5 or 6 months back. Somehow it got slipped because of the you are in queue. I am very happy. Whenever somebody is asking me, I have to answer you are in queue, because a lot of people are waiting, and the majority of the sessions were done from Karnataka by Karnataka faculty, and this Yenepoya is also from Karnataka faculty, and Dr. Vinayak Nayak is a DM cardiac anesthesiology. He has done his DM cardiac anesthesia from the prestigious institute Jayadeva Institute of Vascular Sciences, and he has done his MD from SDM College, Dharwad, MBBS from Father Muller Medical College. So he is working in Yenepoya Medical College for 5 years, and he is a member of scientific review board, and he is an empaneled anesthesiologist for the Center Craniofacial Anomalies and Smile Train, and he is a BLS ACLS coordinator, and he is a PG guide in Yenepoya Medical College. And again, I don't know whether Dr. Vinayak copied Yumna or Yumna copied Vinayak. Probably Vinayak is a senior, so Yumna would have copied Vinayak in reading and painting. Both are interested in reading and painting, but Yumna is interested in cycling. To make a difference, Vinayak is interested in pencil sketch. I don't know, if you give a pen, he will not do anything. If you give a pencil, he will sketch everything very perfectly. So we will arrange a painting competition between Dr. Yumna and Vinayak. We will see who will win the thing. And I request Meghna Madam to be the judge for their painting competition. Also, it will be followed by Dr. Thippesway. Thippesway is a professor in Yenepoya Medical College. And even from the face, he is looking like a Gujarati. He has done from MD from MP Shah Medical College, Gujarat, but MBBS from Mysore Medical College. And his experience is more than 15 years in anesthesiology, and he is interested in pediatric anesthesiology. Naturally, he will smile like a baby, and he is interested in pediatric anesthesia. More than that, he is interested in transplant anesthesia and onco anesthesia. But the best part of it is he has dedicated his life for simulation. He has joined Yenepoya because simulation lab is very good at Yenepoya, and he has 6 publications to his credit, and he has delivered lectures in various conferences. And if the stalwarts are participating, we have to have a stalwart as moderator. So it will be moderated by Dr. Meghna Mukund. He is in charge of emergency medicine and simulation lab. He is a visiting professor in Yenepoya Medical College, and Madam has done her fellow in intensive care in Newcastle upon Tyne Hospital, UK. So if your knowledge is wide, you will be respected even by a foreign faculty, and it is natural. Whenever in India, if you say that you are trained in foreign country, then you are respected more. That is still, it is a scenario. But Madam, after getting training in UK, but now India is offering training in many specialities. That means India has become a developed country now, as far as medicine is concerned. And he has trained in an overseas fellowship in Hull Institute of Learning and Simulation. So after that simulation training only, she has become the in charge of simulation lab. And Madam was professor in anesthesiology in Yenepoya from 22 to 24, 2 years. And from 25, she is professor and HOD. She was a professor for emergency medicine also. Now she is in charge of simulation lab. And Madam is a IMA member, ISA member. And currently she is the ISA secretary. And Madam has 5 international publications to her credit. So with all these trainings in a foreign country and a simulation, she is a standing example. So she is standing example for the people to follow her, and they have to simulate her. And in addition to all these curricular activities, she is a classical dancer. So, but nobody is singing here in the faculty. So, Madam is a good dancer, and in the department, everybody is dancing to her tunes. But she herself is a dancer, and now she is stranded in the airport. Now she is stranded in the airport. She is on her way back to home from Nagaland. But even then, from the airport, Madam is attending this webinar. Actually, I was a little bit annoyed why Madam is stranded in the airport when the thing is fixed. But I have not raised my voice for the simple reason Madam is a qualified black belt in karate. So I have not ready to agitate. So let madam come or not come. She need not depict her talents in karate black belt to us. So madam is a fair lady having a black belt. So that is a cause for concern, and she is interested in badminton also. So with this introduction, I hand over the session to Dr. Meghna madam to take it forward. Thank you, ma'am.
Thank you so much, Dr. Meenakshi Sundaram sir, for that lovely introduction. But unfortunately, because of all the Indigo flight problems, I couldn't reschedule the flight. And I'm very keen to be a part of this program. And many thanks to you and your entire team for allowing Yenepoya to showcase their experience in this topic of simulation. And to all the viewers who are here, simulation is a very niche topic, and all the institutes and universities are very keen on building a simulation lab, getting all the equipment, and building their faculty. But how many of them are actually interested that the students should know what are the uh, what the value of simulation-based learning is? And I would like to highlight that simulation is not just an educational tool, but like Sir rightly pointed out, that it can be a tool for the patient safety as well. And not just through learning, there are so many modules of simulation that simulation is now has been involved and implicated in bringing about a change in the hospital system processes, not just as an educational tool, thereby promoting patient safety. We all work towards keeping the patient safe. And it's interesting to note to all the students that when we, at least when we studied, we were taught all technical skills. In India, we're very good at technical skills, but it is interesting to note that medical errors and medical issues in the hospital happen because of lack of non-technical skills training. And simulation does exactly that, that it brings forth a group of students, put them in different scenarios, and see how they perform as a team, the team dynamic, and the debrief with the students. And most important, there are key important points in simulation. It's mainly dealing with reflective learning. You reflect what you have done right, what can improve, and then take home these messages. So thank you so much, Dr. Meenakshi Sundaram sir, for highlighting the use of simulation and bringing us forth this evening that simulation can help in promoting patient safety. Thank you so much, sir. Over to you.
Madam, you can ask the first speaker to deliver the lecture.
Yeah, we'd like to invite the young and enthusiastic Dr. Yumna to deliver her talk. Over to you.
I'll just share my screen. Thank you for that very warm and kind welcome, Sundaram sir and Meghna ma'am. So our topic for the evening is simulation, and my area will be types of simulation. I'm Dr.Yumna Aboobacker, a second-year postgraduate at Yenepoya Medical College. So a brief overview on what simulation is. So the word simulate means to give effect, imitate something, which means that it is a set of techniques that is trying to replace or amplify the real life experiences by a planned experience, through a planned experience. So the experiences are often immersive in nature, and they evoke or replicated substances or things that we see in real life. And it is fully interactive as well. So it was designed to improve on technical as well as non-technical skills, like Meghna ma'am told, in a way that does not pose harm or risk to the patients. So why are we interested in simulation so much, or what all does simulation give us? Simulation is primarily a tool for training and education, training our technical skills, our base skills, our language skills, our communication skills, and also storing up our information bank, collecting the information. It can also be used for research. Research can be on the type of simulation that we're doing, or research on how simulation is improving the patient outcome, improving performance, etc. Performance assessment is also another use of simulation where the simulation trainers can see individually and as a group how you fare, where you're lacking and where you need to improve. It is also useful for probe testing, which is basically the protocol testing. Every hospital has a set of protocol for different scenarios, for different sessions, disaster management, etc. So simulation helps us to carry that out and see where we are lacking, where we need to improve on, and what all we need to strengthen going forward. It can also be used for equipment testing, that is in part with biomedical industries, the different anesthesia machines that we have, monitors that we use. Are they up to the mark? Are they responding to the needs of the clinicians? All of this can be assessed. So going into a brief history, simulation actually in anesthesia has been started from the early 1900s with CPR mannequins, and it was actually 1960 with Resusci-10, which was the first widely used CPR mannequin that it was established. And in the late 1960s, Sim1, which was the first computerized patient simulator, came to be. And Sim1 was actually very ahead of its time in terms of technology, replicating the high fidelity simulators of modern times. And it set the stage for modern simulators. In the 1980s, Dr. David Gaba and his colleagues actually came up with CASE, or Comprehensive Anesthesia Simulation Environment, which was a virtual setting in an OR setting with a computerized mannequin scenarios, which also focused more on your non-technical skills, your teamwork, your role of communication, as well as your technical skills. And it also came up with ACRM, or Anesthesia Crisis Resource Management. Dr. Gaba is actually credited as one of the pioneers of simulation in anesthesia. And he adopted this from aviation industry, where they have cockpit resource management, CRM, and adapted it into anesthesia and medicine as ACRM. And in the 1990s, we saw HPS, or the Human Patient Simulator, which is most of what we have right now in our megacode scenarios, and SimMap. And the 2000s saw the global adoption of simulation, not just in residency training, but in ACLS courses, BLS courses, PLS courses, etc. This is on the left is the Resusci-10, the basic mannequin. The second picture is that of Sim1, which was with the computer and the mannequin as well. And HPS is a human patient simulator. Coming into types of simulators, there isn't actually a widely accepted classification for the types of simulators. They are very varied. But when we look at the types in terms of their increasing in realism, we can classify them as part task trainers. They can be screen or computer-based simulators, whether they can be full-scale or high-fidelity simulators, and virtual reality-based simulators. We'll be looking at each one. When we think about part task trainers, these are basic models or mannequins that are designed to teach specific procedural skills. They can be for airway management. They can be for laryngeal mask insertion model. As we see in the picture here, this is a peripheral venous access arm. It can also be for central venous catheter insertion model, as well as for spinal epidural block model. This, what we see here, is a spinal and epidural block model. And the one on top is your airway management model, which has a feedback mechanism also, which lets you know if your intubation has gone into the trachea, into the esophagus, if there is more impingement on the teeth, etc. Next is your computer-based simulators. So these are physiology model-driven software systems that features case-based simulations like drug and gas interactions and all. It assists in decision-making and crisis training through virtual means that is both cost-effective and easily accessible to individuals. The first example is your GasMan, which was developed in the 1980s. Is still in play. It is basically a play on your pharmacodynamics and pharmacokinetics of the inhalational anesthetics, which shows you can input the patient weight, the agent that you want, and how the certain anesthetic agent is being uptaked by your lungs, by the different alveolar tissues, etc. Then we have the anesthesia simulator, which is developed by Ainsoft, which is still in play, which is a case-based scenario system. It is perioperative, it has pre-operative and operative as well as post-operative, along with a virtual OR setting. You have your monitors, you have your patient characteristics. It has over more than 80 cases where you can choose and learn. It is self-learned. Coming into high fidelity simulators. So high fidelity simulators, they capture the full complexity of the task, which includes the application of your technical as well as your non-technical skills and the complication that comes with working with multiple personnel, whether it is within your department, with other departments, etc. So what we use for high fidelity simulations is your whole body mannequins that have integrated physiology engines. So these mannequins are actually reactive to your vitals. They have pulses, they have breathing and voice capability and pupillary changes as well. So I told the word fidelity. So what does fidelity mean? Fidelity is just the something that replicates the real world conditions, the accuracy with which this replicates the real world conditions. So it has different concepts. It can be physical fidelity. How does the mannequin feel? Is it as real as the real life patient? How does it look? That is your physical fidelity. Then comes environmental fidelity. Environmental fidelity, how much the simulation where you are in resembles your real life OR, real life ER, and how much you can get into it. Equipment fidelity is how well your mannequin or your equipment responds to the interactions and interventions that you're doing, like we saw. And psychological fidelity is how much you can immerse yourself into it. So they can be high fidelity, like we said, it's a fully immersive experience, or low fidelity. So low fidelity means it's just simple models for skill training, as we saw with task trainers, IV arms, airway mannequins, etc. And medium fidelity means there is limited physiological response, but it is more interactive and it is used for scenario-based teaching, like we saw with the computer-based simulator. So it doesn't automatically mean, contrary to what we might think, that maximum realism does not automatically guarantee that it is maximum teaching. So it is not needed or desired for all the simulations, because our end goal is that we enrich our learning experience. So it should be tailored to maximize that. What we see here is your human patient simulator. In a normal setting as well as in an obstetric setting. All of these are images from our own simulation lab. And this human patient simulators is what we use in our mega code scenarios. That is depicted here in this video, where in your code scenarios, you have a team working together based on a scenario that is presented to you, where you will have to do the necessary interventions and it will proceed according to your response. So we see the team here, and then beyond the console room, in the computer console room, there are people, anesthetists or technicians who are inputting these values into the human patient simulator, which will then reflect and react accordingly. We can see the pupillary changes, the blinking, and what we do next. So these are for your code scenarios or other simulation scenarios. So next is your virtual reality and augmented reality simulators. So augmented and virtual reality is something that is still coming up. So it uses head-mounted displays in virtual reality, it is replacing your vision. Your entire 360 vision is being replaced, while augmentation reality is overlaying a computer-generated image onto something in real life. So it creates a 3D environment for procedural training as well as crisis rehearsal. So the examples we have bronchoscopy virtual reality-based operation theater crisis scenarios, virtual reality airway management, as well as ultrasound-guided regional block simulators. So we can see here, this is a virtual reality. It uses virtual reality to teach ultrasound-guided needling skill for regional anesthesia. It can be helpful in order to practice that skill, get into it, and then take it out on actual patients. So this is again reducing patient harm and risk to patients. Hybrid simulation is basically when we are combining different types of simulation modalities during a scenario. It can either be done in parallel or it can be done one after the other. So as I said, there is no set classification for the types of simulators we have, but the important and named ones are Cumin and Meri classification. It is classified based on user interaction. What are you interacting with? Are you interacting with the screen? Are you interacting with a mannequin? Are you interacting with a real patient? So it depends on that user interaction, it is classified. Then physiology based, is it responding to the interventions that you do? Is there drug interaction? Is there interaction for your anesthetic agents? Is there a physiology based, whether manually put or computer controlled? And use, and how all are you using it for? And Dr. David Gaba's classification actually goes along. First one is verbal simulation. This is purely theoretical. So it is based on what if scenarios. So it is discussion based. What if this happens? What if that happens? So then we go on to standardized patients. So standardized patients are actually actors who are role players who are assuming the role of the patient and the set of symptoms that they may have in the scenario and then acting them out. Standardized patients is actually very helpful in cases of conditions where you need to break bad news or to have improve on your communication skills in that. And part task trainers, as we saw, that is based on a specific skill set. Then computer patient can include your computer-based simulation as well as your VR-based simulation, AR-based simulation, all of that. An electronic patient is where your high-fidelity simulation comes into play. This is a patient that has electronic computer-based inlay in it that responds to all of your interactions with it and makes it more real. It increases the realism. So all of these are the types of simulators, but as I said, our end goal is always enriching our learning curve, improving on it, and making sure that when we do the same in a real world, we are not proving or doing any harm to the patient. So more on that, Dr. Vinayak will be speaking on. These are my references. Thank you.
So Dr. Meghna, madam.
Yes, sir. Next, we have Dr. Vinayak, who will be talking about the role of simulation in enhancing patient safety, a very important topic for all of us as anesthesiologists. Over to you, Dr. Vinayak. Vinayak, I think you're muted. Could you unmute?
Hello, apologies. So I'll be starting on the role of simulation in enhancing patient safety. So the agenda of today's talk would be, we'll be going through simulation and patient safety, and we will see what constitutes a safe learning environment, what is meant by translational simulation, what are the things that are required to improve technical and non-technical skills of the residents. So how does simulation help in management of high-risk events as well as rare events? So how does simulation help in error identification, system improvement, debriefing, which is referred to as the heart of simulation, and challenges and limitations of simulation? Okay, so as we all know, at the end of it, patient safety is the core element in high-quality healthcare. So simulation-based environments offer a safe, controlled environment to practice clinical skills. Now, this is a little different from what used to happen. We are all familiar with apprentice-based models, wherein there is an experienced clinician who guides the resident through their journey in their post-graduation and things on and so on. It can happen even during the undergraduate courses. But how have things changed? Over a period of time, people have recognized this particular apprentice model has its inherent limitations. That is, not all residents can have the benefit of having great faculty, great teachers. There could be variability there. The exposure levels could be different. So because of that, simulation is one of the ways which will even things out. So, and it is the way things go forward. Okay. So this image, what you see on your screen, is a landmark image in the history of aviation. So as you can see here, this is a US Airways flight. So you can see that the passengers are stranded on the wings of US Airways plane 1549. Okay. So it had landed on the Hudson River. So this is the another image. What you see on the right side of the screen is Captain Sully Sullenberg, who was the captain of that particular US Airways. This is one of the few recorded successful water landings in the aviation history. So this, in aviation terms, they call it the ditching maneuver. So as anesthesiologists, since we as anesthesiologists often liken ourselves to pilots in the cabin, so one of the things that naturally comes to us is, how do the pilots practice these maneuvers? Obviously, we are not seeing them do it in practice because we are not seeing it happening in our seas and things like that, because it has cost constraints. So the only way the pilots can practice these maneuvers is by simulation. So this is the reference which we have to simulation. So as far as simulation and patient safety is concerned, simulation enhances clinical judgment. As Dr. Yumna had previously mentioned, that we have now high fidelity mannequins. So high fidelity mannequins can simulate a host of clinical conditions. They can mimic the various types of breath sounds. They can mimic various cardiac murmurs. They can have a seizure, pupillary responses, and so on. More importantly, when we have a good scenario, what it essentially does is it assesses the resident whether they can diagnose a particular situation. For example, let us take the example of local anesthetic systemic toxicity. So does the resident understand that this could be local anesthetic systemic toxicity? That is clinical judgment. And subsequently, because we have high fidelity simulation, which can simulate a seizure, you can also see how the resident, if at all, encounters such a situation, how the resident goes about managing this. Second thing, strengthens teamwork and communication. So simulation, as this we come across very often in our ACLS drills, wherein teamwork is very, very important. Most of the people who have undergone ACLS simulation would realize that the marks are always for the team leader. It depends upon how the team leader assigns different roles for different members of the team. So one could be in charge of compression, one could be in charge of defibrillation, one could be in charge of the airway, one would be in charge of drugs, and so on. So what it does is it enhances the teamwork and communication. It provides a hands-on experience with rare or high-risk scenarios. Suppose there is for example, if there is a venous air embolism in the OT, this is not something which we come across on a daily basis or routinely. So what do we do if at all there is a suspected venous air embolism? First of all, how do we recognize? And if at all there is a venous air embolism, how do we go about managing that? That is provided by simulation. Next, it promotes reflective learning. At the end of every simulation exercise, there's something called as reflective learning, wherein the resident actively sees what were the things that have gone right during the simulation, what are the things that can be improved upon. So there has been a lot of talk about safe learning environment. Why this entire simulation exercise is meant so that the residents learn safe practices. We also have to emphasize that their psychological safety is very, very important. This is something at the beginning of every simulation class, we inform the residents that they are learning in a judgment-free environment. What happens in the simulation lab stays in the simulation lab. So we do not discuss scores of the residents. We don't pit one resident against the other who has done well in a simulation. All their scores are known only to the course coordinator. So this provides a safe learning environment for the resident. So basically, it's a no-risk environment or minimal risk, we can say, because if a resident is learning by the conventional methods, of, say, for example, central line insertions. So they will be exposed to blood, various kinds of bloods. Some could be seropositive and so on. So which exposes them to various, they can have needle stick injuries. Whereas in a simulation, when they're cannulating, although we tell them various safety precautions have to be taken, but it is much more safer learning and practicing this on a mannequin and then subsequently moving over to the patient so that they have a higher success rates. One of the things which students enjoy a lot is ability to repeat procedures. So this, unfortunately, when since in our field, time is key, we have very less time to react. So it is not possible sometimes to give endotracheal intubation chances in a critical emergency to a newly freshly joined resident. So in a simulation lab, it is not so, where the resident has adequate opportunities to practice different procedures. So opportunities to fail safely, as I had mentioned earlier, especially UK-based organizations are very much endorsing this particular thing of allowing the resident to fail. This is the place where they fail and they learn. And constructive feedback is always given at the end of every simulation session. So there is something called as MAGAGIC's Translational Simulation Research Framework. So to simply explain, I'll explain it with an example. So there is something called as T1 simulation. For example, let us assume that we are teaching endotracheal intubation in the simulation laboratory. So a resident who comes with absolutely no knowledge about endotracheal intubation, at the end of the session, they would be able to intubate. This is called as T1. A lot of studies have been done on T1 simulation, and they have found excellent results that a resident who absolutely had no idea has decent clinical skills at the end of the simulation session. But this becomes just T1. So when this resident goes back to the OT, and if this resident is able to intubate in the first pass, say relatively, which is not a complicated or a difficult airway, so then we say that we have achieved T2 level of simulation where it has changed the clinical behavior. Most importantly, at the end, the heart of simulation is we have to reach T3. So suppose a resident has diagnosed a person in hypoxia or in respiratory distress and has gone about intubating. And because of this, the outcome of the patient is good. So that means that we have achieved the ultimate goal of simulation, that training, that is to achieve T3 outcomes. So it goes without saying that simulation practices improve technical skills. So there are different methods by which this can be done. One is something called as deliberate practice. So deliberate practice is usually done on task trainers. It could be endotracheal intubation. It could be airway heads, through which you can practice endotracheal intubation. You could have you could have various kinds of mannequins through which echocardiography can be practiced. So basically here, what is the method that which we follow? There is something called as the DOAP technique, where initially the teacher or the facilitator, we call them as facilitators in the simulation lab, they demonstrate a particular procedure. The resident observes, so DO. Then next is the assistance. That is, the resident now performs that same procedure under assistance. And finally, the resident is allowed to practice or perform it independently. So this is the DOAP technique, and they can repeat it as many times as till the point they are comfortable and they are confident. Now, a lot of emphasis has been given to blended learning because there are a lot of e-learning resources that are available, even including our ACLS now comes as a combination of both e-learning plus simulation. So usually the residents have to read up the reading material that is provided to them before the classes, and subsequently they have to answer some MCQs that are being provided, and finally they come for hands-on experience to the lab for simulation practices. So there's something called as Kolb's learning cycle. Here, what happens is that the resident basically looks like, say, for example, we have created a particular scenario. The resident is observing that particular a senior resident who is performing some activity, say, for example, endotracheal intubation. So the resident assimilates that, okay, some form of respiratory distress has gone on. So because of which my senior has intubated. So that gives a important amount of learning for the resident, that he has noticed that the saturation is going down and so on and so forth. Subsequently, there will be a debriefing session where the facilitator comes and discusses with the candidate with the students on what are the things that went right during the simulation and what are the things that could be improved. So then again, the resident understands that, okay, these were the things that my senior has done right, and these are the things which could be improved upon. Subsequently, they will have some degree of base knowledge that they have. They will try to link it to what they already know or what they have already experienced. And finally, the active experimentation, they might ask, could I have put a supraglottic airway in this particular device? Can I try it? So this helps the resident to reflect upon and thereby improving deep learning. So next is facilitated debriefing. Facilitated debriefing is basically, there are a lot of techniques for debriefing. Advocacy inquiry is one, wherein the facilitator tells what are the points that the facilitator has observed during the process of simulation and asks for opinions from the people or the learners there. So basically, there is we don't try to say that you're wrong during a simulation program. We just take their opinions and we treat them respectfully. So improving technical, what are the skills that can be improved technically in a simulation lab? It could be basically airway management. Like we can see in the images, there are different, you can teach the residents about endotracheal intubation. You can teach them about supraglottic airway. As you can see, madam is teaching the resident how to insert a supraglottic airway. You could teach them cricothyroidotomies, tracheostomies, and so on. BLS, ACLS are usually done on mannequins. As mentioned, our history of simulation starts from Precisely Annie. Then various even simulation practices are useful for surgical residents as well, where they practice intercostal drain insertions. They will learn different forms of suturing and including laparoscopic procedures or laparoscopic skill training is done in the simulation lab. Medication administration, it could be as simple as teaching a resident what kind of clinical conditions, what infusions are you going to consider, whether you'll start a vasopressor, whether you start inotrope. If yes, how would you dilute it? How would you switch on the pump? How would you start the infusion, and so on. Then infection control practices. Several studies have shown that if the nurses and surgeons and various clinicians undergo this infection control practices in the simulation lab, they will have better outcomes in the wards. It has led to a significant decrease in various infections, hospital-acquired infections. So enhancing non-technical skills, like madam had mentioned, that it's not just the technical skills which will decide the outcome for the patient, it's also the non-technical skills. So something called as situational awareness. This is one of the first things that is usually taught during a BLS course. First thing that a resident or any trainee is taught is look for scene safety. Are you safe? These things do not come naturally because our first response as doctors is to jump in and start CPR, because we have learned in theory that we just have about 3 to 5 minutes to initiate CPR. But the situational awareness is very, very important. Are there any fires? Are there any electrical connections nearby? So all these things also play a very important role in improving the outcome. Clinical decision-making, as we have seen, that various kinds of scenarios can be created in the simulation lab, could be local anesthetic toxicity, venous air embolism, and so on. So in such a situation, what is the best? It's okay to make errors during the simulation practice so that when, if at all, we hope that none of us face complications, but complications is something that is unavoidable sometimes. So if at all we face, are we prepared to handle that situation effectively is the question. Then leadership under pressure. So in simulation, we can create a lot of things, but we may not be able to completely mimic what happens. Say, for example, there is a PPH going on, the obstetricians are under stress, the anesthesiologists are under stress. So exact OT environment, we may not be able to simulate, but yes, the person who has undergone these kind of training practices is better equipped to handle the situation and knows what is the protocol that needs to be done, especially when there is a major obstetric hemorrhage. Interprofessional communication, very, very important, because during a process of simulation, we don't only meet people from our discipline, we also meet surgeons, we meet orthopedicians, we meet nursing faculty, we meet paramedical. They all should be treated respectfully. They all play an integral part in healthcare. So this interprofessional communication is another non-technical skill that we learn. And team coordination. Otherwise, even for a dance choreography, it has to be synchronized. So if everybody is doing everything at the same time, it looks chaotic. So team coordination becomes extremely important. One person takes the leadership during that period and then assigns roles, and everybody has to keep the egos aside and do what is being told, so as they can always give constructive feedback to the team leader, and team leader will listen to the person and reflect upon it. So it definitely helps in enhancing non-technical skills. Recently, in a state conference, there was a workshop where a scenario was created wherein obstetric patient who was given labor analgesia. There was a small piece of epidural catheter which was left behind. So how would you break this bad news to the patient and the relatives? So that was taught during this particular program. It was very nicely done. The spikes protocol was very nicely explained. So this also prepares them for situations like that, to how to avoid conflict. So this also becomes an important part of learning. So as mentioned by Dr. Yumna, GABA and colleagues came up with crisis resource management, initially adapted from the aviation. So he mentioned that call for help early, anticipate and plan, know the environment, use all the information that is available, allocate attention wisely, mobilize resources, use of cognitive aids, communicate effectively, distribute the workload, re-establish role clarity, and designate leadership. Although this seems that this is basically common sense, but these things, non-technical skills, do not come very easily unless it is practiced. So when a resident enters the department, first thing they are told is, in case of difficulty, call for help. That is the first thing that you teach. As important as their technical skills are important, even non-technical skills become equally or sometimes even more important. So the Joint Commission, which is basically a US healthcare accreditation body, has said that 3 out of 5 root causes for sentinel events in anesthesia are all non-technical. It is because of problems in communication. That's why during the ACLS classes, the closed loop communication is so heavily emphasized, wherein if a drug is given, the nurse has to confirm once again with the team leader that, am I injecting 1 milligram of adrenaline? If the team leader says yes, only then it is injected. There are various human factors that are responsible. So, and leadership again plays a key role. So practicing rare or high-risk events, like intraoperative pulmonary embolism. How do we diagnose a pulmonary embolism? What do we do in case there is a pulmonary embolism? How do we manage? What is the course? So these high-risk events can be practiced during simulation. Postpartum hemorrhage, as I discussed earlier, the blood loss, what do we do? Simple things like securing a large bore cannula. All these things can be discussed during the debriefing sessions of postpartum hemorrhage. Some are time sensitive, like cardiac arrest. So how quickly do you recognize a cardiac arrest? How do you start high quality CPR and ensure that the patient has ROSC? So these things can be practiced. And complex like mass casualty events. This is extremely important. This has been practiced in various centers, including our own. This is called as Code Yellow, wherein it involves a multidisciplinary approach. So basically, the police are involved, the administrative team is involved, the doctors are obviously involved, anesthesiologists, as usual, will be in the forefront. There will be emergency physicians involved, orthopedicians, surgeons, and so on. So we hope that we don't have this mass casualty incidents, but suppose we end up with a mass casualty event, we should be better prepared. Basically what the drill encompasses on how triaging is done. So how do we go about that? What are the things that could go right? What are the things that could go wrong during this particular, because even the emotions are running high. There is a lot of agitation, there is a lot of panic. So practicing always keeps us a step ahead when we handle these kind of complex events. So error identification and system improvement. Simulation exposes system level vulnerabilities. So what do I mean by that? Say, for example, we have done our simulations, exercises, we are well trained in intubation, but still, is the hospital ready? How do we check? There is something called as in situ simulation. So basically, you can call for a code in the hospital and then check how quickly there is the emergency team response. Apart from that, this will expose. See, we might know how to bag a patient, but is the ambu bag working? Is the laryngoscope equipment in order? So these things become very, very important as well. Workflow inefficiencies. Is the lift working? Is there a communication breakdown? Was the intercom working? Policy gaps? Was the administration informed? So there are a lot of things that come out at the time of simulation, especially that of in situ simulation, and thereby overall the error can be identified and the system can be improved, all for improving the patient safety. So debriefing, as I mentioned earlier, debriefing forms the heart of the simulation. After each scenario, a structured debrief helps participants to reflect on their performances. There are different ways to debrief. There is something called as plus delta debriefing. So basically, you do not discourage a participant who has taken part in the simulation. You just, either it could be verbalized, or in some centers, they also record the performances of the candidates. So net result will be they reflect on the performance, they will inform what went right, what did not go well during the simulation. They identified the strengths and more importantly, the limitations. So then the facilitator tells what was the rationale behind the actions, what should have been done and what is the rationale behind it, and what is the ultimate aim. It is to develop strategies for further improvement. So what are the challenges and limitations of simulation? First is cost of high fidelity equipment. These equipments are especially when you're going for high fidelity simulation, these equipments are quite expensive. There is annual maintenance cost that is involved in you have to appoint biomedical engineers who look after the hardware as the software issues. There could be wear and tear of these devices. So the costs start escalating. So there are, if we inform the patients regarding this, while they're happy that the doctors who are treating them are undergoing simulation, but they're also concerned whether the cost of the training is going to be passed on to the patients. Same thing with the trainees who undergo this particular exercise. The concern which they might have is the cost going to be of procuring this mannequins going to be passed on to me? But a lot of studies have said that simulation definitely, overall, if you see the bigger picture, simulation improves healthcare. Time and resource and equipments. For having a successful simulation, one, you should need trained faculty. There should be several faculty development programs, which again is time consuming. It requires resource allotment. It requires budgeting and things like that. And more importantly, clinicians are busy, so it requires time. So these are some of the challenges. Need for trained instructors. There is absolute shortage of trained instructors in the field of simulation. There needs to be more trained instructors for simulation who have undergone various faculty development programs so that the best experience can be given to the trainees. Ensuring realism and scenario quality. So the students really enjoy when it is very close to normal. So ensuring realism is extremely important during any form of simulation. And finally, we have to, in a nutshell, to say simulation is a powerful tool that enhances patient safety. It improves clinical skills, decision-making, teamwork, and system reliability. When implemented, it leads to effective and good patient outcomes. Thank you, one and all. I thank ISA Puthukkottai for giving me this opportunity to present at such a prestigious forum. Thank you.
Thank you, Dr. Vinayak Nayak. You have elaborated all the skills involved in simulation lab, technical and non-technical. We will be taking the questions at the end. And now I request Dr. Thippesway to proceed with his lecture.
Good evening. I think Dr. Vinayak and Dr. Yumna both told a very good introduction, so much into the simulation. So I'll be telling as an anesthetist how much we need simulation or why simulation is very much, you can tell that simulation so much interested with anesthesiologists, and simulation is very popularized in whole of the healthcare by anesthetists. Okay. Now, patient simulation and anesthesiologists. Okay, we all know that anesthetists are the team leaders when it comes to the simulation, because it's mainly the simulation is needed in training, research, system probing, and performance assessment. That means every part of teaching, we require a simulation. And by doing a simulation are by making the people to go through simulation, we develop something called as culture of safety. So as Vinayak and Yumna pointed out, the safety becomes very important when we have administered anesthesia to our patients. So the safety comes through simulation. Okay, now why simulation is again important in anesthesia? Because anesthesia involves patient
Dr.
safety,
Thippesway,
and we all know that.
Dr. Thippesway, sorry to interrupt. Whether you are having slides or you are talking on your own, you have to go for your slide share.
Slide share didn't happen, sir. Okay, thanks. Sorry for the things. Actually, it has to come. Sir, it's coming?
No.
Oh, till now it was coming.
You open already, you have done it. No? You open your PowerPoint.
Yes, sir. Yes, sir.
Then minimize it. Then go for share screen. Then click it on that icon. Yes. Now it is. Yes, coming. Please.
Okay. Sorry. Apologies. So, okay.
Move the next slide. Yes.
Okay. So we all know that patient safety comes first, rare event preparation, and the team coordination. It is very much important when we do the simulation. So 1 minute. It's coming, sir.
Yes, you move the next slide. Please don't ask whether we will interrupt. Okay. You move the next slide.
What is the importance of next slide, sir? It is. Why it is important with human performance and patient safety. So whenever we talk about patient safety and when we talk about anesthesia, there is something we always take about human performance. Okay, so either it may be the human performance of anesthetist itself or about the patient himself. So why it is very important to know about the human performance in terms of a patient safety. We all know that 80% of avoidable events or the drug errors occurs due to human factors. That's huge. So the very important or a simple thing to prevent the human errors is through simulation. The human factor related safety strategies actually individual and the team, it's actually indispensable. Say for example, it may be to the potential of to harm the patient, or it may be to potential problem for the professional himself. For example, human factors, you work for a long duration. So that itself becomes a potential for the second victim, that is an anesthetist working. So we all know that the first case, how we do give anesthesia, and if you're working on a 24 hours and you have all the bad cases on that day, how it becomes to work on the last day of the hour. So we know. So that is the individual and team factors, human factors. Next, organizational safety attitudes are essential to support high individual performances. Okay, so we all know that organizational safety especially comes through training anesthesia professionals in human factors. Even in anesthesiology, we have a long way to go in terms of complacence. We should not be complacent, so we need to have a quality improvement. So this intermittent quality improvement can be done through simulation. So we all know high stakes of anesthetic practice. Most of the time we encounter in a critical incidents, we have a very less response time when it is a critical, and the margin of error is very less. So what we all, based on the work of Osen and colleagues, what they told, anesthesiologists by its nature, they involve too much of crisis environment. So we all, even though we tell that anesthesia is a long or boredom, excited by the intermittent adrenal rush, but it's not like that. So when we work as a team, or when you're working in the anesthesia, or when you're giving an anesthesia in the operation theaters or outside, so we work in so much of environment, so much of factors interplaying at a single time. So starting from ill-structured problems, we have a dynamic environment, then we have a ill-defined competing goals, high stakes, organization goals and norms, uncertain systems, time stress, short action loop, and multiple players. So to know that we all know each things I need not explain, that is how the complexity of anesthetist works. So this is a real-time problem-solving behavior. This is called core cognitive process model. So if, say for example, if anesthetist is working and the OT, we have multiple levels which an anesthetist has to go through or think. He has to at least work on 5 levels. So first is resource management level. So for example, what are the resources he need to give that case? It also includes leadership and communication. Next is supervisory control level. So data, what is going on, which prioritization you have to do, which activity you have to see, and whether he has learned or not, interruptions, all those things. The next comes at the once he comes there at the sensory motor level. So what is observation, whether the observation is correct or not, whether the data what he is seeing is correct, or whether he should be able to rectify that, or the data itself is wrong at that point of time. That is all the procedural level. So whether he is just doing an intubation, whether he is ready to know the anticipated problems or not, that all comes in the procedure level. And the last comes as abstract level. So that is what is the error or what things can go wrong. He has to judge based on the patient and the surgery itself. So he should know, okay, these things can go wrong. All this complexity environment or a problem solving behavior, it has to act simultaneously and the anesthetist has to work. So this is how the complexity works. So in this, so patient will have so much of elements, this observation, verification, problem recognition, then decision making, action implementation, reevaluation, and start again with them. These are the things what he has to do when the mental activity or when the case is going on. So all these things are very easy if are learned through simulation. So everybody will be thinking why simulation is needed even for the residents or things. So at Dr. and pointed out that we have had a traditional apprenticeship model where it is popularized by William Halstead. So see one, do one, and teach one. So as Vinayak rightly pointed out, so many times we do not have a good mentors. Many times we do not have mentors in all the places, or we may not like. So our outcome, our students should not suffer what we suffered. Okay. And the new thing is Generation Z learners. We all know how the post-graduation curriculum has changed, like how we learned, or I think Meenakshi sir will be knowing how sir learned. It's entirely different from what the present generations are learning. They are very much prone to having a gadgets, information is everywhere. They don't know what to learn or what to concise or what to comprehend. That becomes a problem. So next is patient safety concerns. So simulation-based teaching can be incorporated also with the patient safety, where you cannot teach everything on the patient. So that's why the simulation teaching becomes very important in anesthesia. So this Yumna told clearly like how we started the simple thing with the resuscitate Annie, and now we have what I'm showing is in the human patient simulator. We call it as HPS. This is the latest simulation mannequin, the high fidelity mannequin what we have in our simulation center, that is Accent, which almost can mimic so many things of a normal human things. So, okay, now coming to, we all know that we had the idea of human factors are important. Simulation plays an important role in human factors. Then why you should learn a simulation and what are the complexity. Now we'll think about what simulation can do, what application can do for anesthetist. Simple things like education and training. We all know it. Vinayak told about technical skills and non-technical skills. Other than that, we have what called a system probing. So we know that in situ simulation, we do it where the problem is happening, or we can take say a mannequin, or we have what is called as METIMAN trauma mannequin. We can take to the casualty and make a simulation drill where we can come to know that what the system failures can happen, which we can tell that active failure and a latent failures, active error and a latent errors. Then equipment testing we can do. It's mainly for the biomedical people who want to. So for example, you found probe or new thing, something called as bioimpedance monitors or something, which needs to be tested. So we can use a simulation. Then performance assessment. It is still a name in our anesthesia curriculum, or it's still in India. We don't use for the performance assistant, but we can still use performance assistant of evaluation of the teaching. So simple thing what we do is our CPR skills, where we use a performance assessment skills. The last is research. So simulation and research is coming in a big way. So you have to do this. Okay, now coming to what all the technical skills in anesthesia, which I can go through simulation. This is the wonderful thing I think we have all told. This is about anatomic table, which I really wanted to tell about the way traditionally what we did when we took an anatomy class. First year we remember where we go to the anatomy table and keep on dissecting and trying to fit. The main disadvantage is what? Say for example, one day you already dissected the major or something on the chest. So the next day you can't have that same dissection part. You cannot come back. Whereas you see this anatomy table where just a simple thing, 3D anatomy table, where you can day and learn, you can move, you can cut, you can paste CT scan, you can put ultrasound image and reimpose on that. Just imagine the 3D orientation what an resident can get. How best he can get the teaching. So that is what small things you can get. Then we have small things called, this Yumna pointed out, we have a spinal models. So we cannot keep on teaching the spinal from on the patient. We know the pain is very important, and two, we always know patient safety is very important. So we cannot make him to go through 3 pricks, 4 pricks in a difficult cases. So the learning becomes very easy in the models like task planners. This is newer thing that is called as ultrasim. They did in, I think in Canada, where they included the ultrasound guided regional block through video VR training, that is virtual reality. So they published it telling that through virtual reality you can do a ultrasound guided regional blocks. Vascular cannulation, I mean, we all know what is so much of difficulty to learn arterial cannulation, and each patient is different. So we have wonderful task trainers for arteriovascular cannulation, especially for anesthetic individuals. Then airway skills are innumerable, starting from cricothyrotomy, pediatric airway, difficult airway. This, I want to tell that this is a fiber optic trainer which we have in our simulation lab. Just imagine that we, many centers don't have a fiber optic, so they cannot take it. So this fiber optic, the best thing about this fiber optic simulations, what we can do in our lab is we can create difficulty level. Say difficulty in mild difficulty to the, even we can have a trauma airway, or we can give the glottic tumor. We can simulate and ask the resident to perform on it. So yeah, you need not have the risk of having something doing to the patient, a harm to the patient, but you can learn. So, and the it's a part of the human patients, what I told HPS mannequin, we can create a difficulty level, starting from a pregnant lady having a difficult airway. We can all create difficulty airway scenarios. So the training which goes the really in a joyful manner, and the knowledge, both shared as good. Even tracheostomy can be done in the simulation. Then very important is trauma and resuscitation. So this is what we told about the maintenance. So suddenly the patient comes with the multi-trauma, and we want to know what the assessment is. How we want to shift a patient with a cervical spine injury. So we don't, every day we don't get cervical spine injury. Every day we get a patient with cervical spine injury. Definitely we can train the residents. Then the newer technique, that is POCUS. So which we have in our simulation lab, the like a task trainer. So we have here, this is a transthoracic echo and transesophageal echo. Both we have in our simulation lab. So we all know transthoracic echo, EFAS has become one of the tools, especially when you do early echo, or everybody should know to do a transthoracic echo to know that when the trauma patient comes, or intraoperatively. We all know that our Vinayak is a cardiac anesthetist, where now in USA, the echo, transthoracic echo is become a part of MD anesthesia curriculum itself. So in India, we have still a long way to go. When I studied, we didn't have a transthoracic echo, but if now I want to get trained, so it becomes very easy for me to get trained. And here, so this, the POCUS one, where the patient can be simulated everything like abdominal trauma, seizures, anything to know. So these are the, sorry for the slide, this is very big. So what I just wanted to tell is these are the various task trainers which we can do in anesthesia. So all the things of what we train first year, second year, and third year, everything can be done, most of it as a task trainers. So this is about the task trainers. But what is very important, or what we cannot teach hands, that is anesthesia non-technical skills. So attitudes and behavior not directly related to the use of medical expertise or drugs. That is very important. So Vinayak pointed out very well about the importance of hands. So especially the cognitive and social and interpersonal skills becomes very important. So the cognitive becomes task management and decision making, whereas the social personal skills, all those are the teamwork and situational awareness. All things are glued by what is called as communication, verbal and non-verbal. We as an anesthetist, we doesn't talk much to the patient. We do not get time to speak to the patient much like what the other specialties do. So the communication per se doesn't mean that we should not talk about nonsense or anything. So, but when something is happening and the crisis is happening, we need a good communication, especially in making a teamwork or the things. Say, for example, simple thing like calling for help, whom to call, quickly or to take a call for help. So that itself is very important. Then situational awareness becomes very important in when you do a crisis. So, for example, many times we see a patient is doing a pediatric patient, they're doing some major surgery, but the bleeding is not visible, but there is a oozes. So in pediatric, the oozes becomes very minimal because we do not give to attention. But suddenly the patient becomes bad because we didn't pay attention to the micro oozes or the smaller oozes. So that becomes a situational awareness where you know that what the surgeon is doing or what the patient is going on. So that becomes very important about the things. So to tell what are the crisis which we get, this is the simple thing list I have given. It doesn't mean limit this list. There are enough of things which we can create and train the anesthetist, residents, and anesthesia practicing anesthetists, because we also have what is called as training the trainees. So where we conducted a workshop to train the anesthetist in so many simulation crises. So starting from difficult airway to acute ARDS, everything can be created just to make how crisis management can also be done. So simple example I wanted to give about an obstetric anesthesia. In obstetric anesthesia, we can create so many things. Okay, so what we did, a basic scenario we did as postpartum hemorrhage and PAH scenarios. A patient comes, suddenly throws a convulsions on table. We rarely see a patient throwing a convulsions on table. Okay, so and suddenly the patient simulation has come and on table convulsions comes. What a resident do, what we do, and how he manages, that becomes very important. And you have given a spinal and suddenly she goes for the hypotension. Okay, so what crisis, how he manages, that everything can be done in a obstetric anesthesia itself. Not only that, even for you can train the coordination, communication between what the OBG does, the gynecologist is doing, obstetrician is doing, and the anesthetist doing, or the simple nurse and the technicians are doing, something like preventing a drug error itself. Okay, now this is about technical skills and non-technical skills. Now the second part of simulation can be used for system probing and protocol testing. This is what I was telling about the in situ simulation. The simulation also has the part is called in situ simulation, where we take the simulation or simulator to the things where it is happening and we do. So basically we can test a system probing and protocol testing we can do. So what it is happening there. So this James represents a famous model that is of causation of accidents. Why an accident or a catastrophe happens on a particular day. So he tells that the model shows the different organizational processes. Each organizational process has a shield. So for example, one day you had a patient of cannot intubate, cannot ventilate, or what we can say now cannot seek vital, cannot intubate, cannot oxygenate, happened on that day. So it doesn't happen all of a sudden in a trained personnel, because you are every day giving anesthesia, every day you are going into OT, but on that day, why it happened? There must be so many things which happen on single day. That is called, we call it as trajectory of accident opportunity. When it, see, each shield has a hole, that is nothing but a weak points. So all the weak points of the system align on that day, it becomes a major catastrophe. That is what happened in what Vinayak told at the aviation industry, what that famous landing. So on that day, even though they did, but they could safely land, but many times they couldn't land, many catastrophes happens. So I think in simulation also, we know when the simulation started, when a famous aviation, I think pilot, his wife went for an ENT surgery and a routine surgery where the anesthetist could not intubate. So finally, lady has to expert, I think that happened. And then he, instead of blaming the system, he, coming from the aviation industry, he took the inspiration and gave the idea of simulation in the anesthesia. That's how it started, the simulation process. So this is called as reason Swiss cheese model. This thing, in situ simulation, can really do it. How we can do why there is a happening of failure, system failure happens. This we can do it. Now, as I told, there is something called as active errors and latent errors. This is very important, and human things happens. What do you mean by active errors? The simple, knowledge-based error, rule-based error, skill-based error. That is, that something has to be read about. Say, for example, suddenly you have a patient of some syndrome which you had not read. So, but you didn't study about that, or you didn't know, and you suddenly wanted to have it comes as an emergency case. So that becomes your knowledge-based error. So you may end up in some problem, or you may not end up, but that is where the error happened. So skill-based error, something you should have got trained. So for example, you didn't get that point of time. So that becomes skill-based errors. So all these things can be very well done, or we can do through simulation. Then latent errors. So for example, incorrect policies, inadequate assistance or supervision, and physiological state of the patient, and we by take by the chances. All these are called latent errors. That's what the Swiss cheese model is all about telling. Okay, use a patient simulator for testing equipment and supplies. This I will not go in detail. This is mainly for the biomedical industries. So for example, as I told, you want to test a human factors for the biomedical industry, something you have started. And say for example, AGM. So new AGM monitor comes. That the human patient, what HPS mannequin which we have, can tell the depth of anesthesia, can give the MAC value. So one new monitor has come. I want to test the MAC value on that patient. So on that simulator, I can do it very well. That becomes a use of simulation itself in the equipment and supplies. Then use of simulation in the performance assessment. That is, we all know how anesthetist residents are, our exams are there. Formative testing is there, summative testing, and research on clinical decision making on care. All these things we can incorporate. That simulation can be used in a technical and non-technical way to, with the assessment tools, we can use simulation in the performance assessment. But still, it is not yet finalized, or it is not so popular because it itself has so many problems. Now, patient simulation for research. This is very, very important. So now we have two types of research we can do with simulation. So Dr. Vinayak pointed out about the debriefing technique. So the debriefing technique is the soul of simulation, like how we can debrief. So all of your learning, like what you did or what you didn't learn, depends on the debrief. Your motivation depends on debriefing. So all of your simulation journals can be done, or the research can be done about how good a debriefing should be. That's all. That's a simple topic of simulation in the research. Or we can use the simulation tools to study something else, like a human performance or something new, as I told, AG monitors. So we have a journal itself dedicated to simulation itself. It started long back in 2007, so by the SSH, that is Society for Simulation Healthcare. So just to give an idea about the people who are attending, we can do various studies on so many questions we can arise, especially we can go ahead with the research. Say for example, cognitive science and dynamic decision making. You can just simple thing like how are optimal action planning and scheduling implemented. So that we can do in a simulation research. Or fail and result in fixation errors. So we all know that we always go with the traditional fixation that, okay, this patient has come, I should intubate with a Macintosh. Even though video laryngoscope is there, or we will not go. No, this is easy, we'll go with the fixation. So so many fixation errors we always do, that can be done. Like human machine interaction can be done. We all know that the monitor gives alarms. Many times we ignore that. Or ventilator alarms. We all know that we don't ignore it. And the same thing can be studied using a simulation as a research. Okay, then teaching anesthesia and operating room, that becomes very, very important. The studies have done like human factors, wonderful studies on human factors, something like use of what is the amount of music which plays in the operating room and the effect of music on the OT environment. That is the study they have done. So that's what kind of music is good for the surgeon and what kind of music soothes the anesthetist. Leave about the patient. There is already, we have done that music therapy improves the patient and it decreases the anesthesia load. That is secondary. So I am telling about the anesthesia and operating room, about the things. And non-technical skill performance you can do, and anesthetist performance, that's what I was telling. Especially deep sleep deprivation, fatigue, all those things we can study. And okay, now types of simulators, I'll try to skip this because both the speakers before me have done justice to this. Screen-based simulators, which is a simple thing we started with. Screen-based simulators like gas fan analysis, what Yumna pointed out. This is what we started with the target. It mainly targets the Miller pyramid from knows and knows how, but we do not go to till the last target of does. That is the last part where it retains for a longer time. Then mannequin-based simulators. This is for high fidelity to the full scale. We have the simple mannequin, which we can use it for this something like a CPR, to the full fidelity where I am telling about the AGM, depth of anesthesia monitoring. Still, I can go with that. So both things I can do on that. So what we should really understand is, it's not the mannequin which is important, it's the program which is important. Like how I run a program of simulation, that becomes very important to create a awareness or create interest into the participants. So airway features, this is one thing which is very important of a standardized patient. It itself can be a simulator. So as I was telling, more concentration on communication, the breaking bad news that spikes that Dr. Vinayak pointed out, that where you have a standardized patient. This is very much used when you go, I think people who attend the FRCA or FSCP, they know that they have a standardized patient where you have to interact and where you have to give an anesthesia, like they will give. So communication skills, they basically assess your communication skills. Then starting from assessment of the pain, we generally think about the pain assessment. How many of us we do? We put an epidural, we give a blocks and just come out. We all depend upon either the surgeon nothing about no patient has a pain. Many times we forget. So the same thing, that something like that we can all have on the standardized patients. That itself is a part of simulation. Then hybrid simulation, you may point out very well, where simulation can be done in a parallel way or it can be done in a sequential pairing. So I will not go into again this in a parallel pairing where I can involve other people. So for example, at a time I can involve a surgeon, anesthetist, nursing people and technician, alternate. So all this together I can do a parallel pairing and run a simulation to test all the people instead of a single team or single individual testing. That becomes a parallel pairing. Sequential pairing is, so for example, you started with a standardized patient, so he gives an history and suddenly he becomes anaphylactic or he turns into something else, and now I shift on to the mannequin. So that becomes a sequential pairing about a hybrid simulation. They are very useful when as per the situation, as per the scenarios you can use. So virtual reality, yeah, this is, we all know with gaming and virtual reality. So this is what the simulation all learns about Miller's learning pyramid. We all know this is understood, like it's an old technique. So we all know that whatever we know, or we know it, like say for example, we teach is only you study, you know, but knows how is when you observe. Say, for example, observing somebody putting in cannulation, you will come to know knows how. But when somebody demonstrates also, like you put a little bit of hands on and shows up, then it becomes a shows up. And lastly, when you perform, it becomes a does. So to know shows up and does, I cannot keep on depend upon the patient to teach everything. So the last part especially does, that is real-time performance. The simulation becomes a very important tool in giving the pyramid. That's the highest pyramid in Miller's prism. That is very important. That's how the simulation helps. Okay, now coming to the simulation sites. I told about why simulation is important in anesthesia, what are the things which we can replicate, what are the types of simulation we did, and lastly, where all we can do simulation for anesthetists. So simulation can be done, very simple thing is, one is the dedicated center. As say, for example, we are proud to say that we have a dedicated simulation center. Like that, now we should thank NMC because they have come out that every center should have a dedicated simulation centers. So now we can get a simulation done there. And next thing is in situ simulation. What I was telling about the in situ simulation before. The probe actually clinical site and systems with the real equipment supplies everything you can test. The main problem is the distraction from ongoing setup, takedown, the people, other things that becomes a main challenges. Okay, now in situ simulation system probing, that it is study. And what we could do is studies in situ simulation revealed that there is a significant insights out of 46 ISS sessions they did over 800 patients. So what they could do, like a latent condition and an active failures, whether they could do it or they could find out. So likely through ISS, they could find out that how much was the failures of active failure, how much was latent conditions. Okay, mobile simulation. This becomes, as I told, say for example, you don't have access to the simulator centers or anything. So from Yenepoya, I can come to some periphery centers. I can do some amount of simulation. That becomes a mobile simulation. So these are the big busy slide where site of simulation to advantages and disadvantages is there. But dedicated center definitely good. But in situ simulation is where we integrate so many things. And last is sequential or mobile simulation, which is for the people who does not have a simulator centers. So who should participate in a simulation? It starts from the students to practitioners and the team. Like team itself can have a simulation participation. Now that simulation is a part of UG teaching, I'm very happy. Like we all incorporated simulation as a part of teaching. Like our anesthesia residents also have at least weekly once, a monthly once, as a simulation classes. They go to the dedicated center and learn the simulation. So the last thing about practitioners, that becomes very important. So for example, as I told, so I am not initially when in my residency, I was not knowing about the transthoracic echo, we didn't do. So that as in practicing, I learned through the simulation. So simulation becomes very important tool to learn about the things which are not learned. Then we had what is called as a workshop. Mainly for the trainees, we had workshop attended by, I think we have eminent people. We got Ravi Shankar sir, we had Hemant Kumar sir, and we have Mukul Kapoor sir coming and teaching us the simulation. So we simple things like a gas induction with AGM and a gas band analysis combined and having the different views. So like it becomes a group discussion, but with the what we have the clinical things and what we can do on the patient. So everything we can judge. So we can relearn. See, the main important thing about simulation is what you learned, you have to unlearn and relearn. That happens with simulation. So single discipline versus multidisciplinary training, that we know that we can have both trainings. Last thing, I think Vinayak pointed out crisis resource management. This becomes very, very important. Historically, we anesthesiologists would have we thought that non-technical skills, we always see that out of 15 professors or 15 people, 20 people in the department or 20 staff in the department, professors. One or two professors will always be fond of every resident because they talk well, they do it well, maybe they are very good to the patient. So this all, and they are good at the crisis management. So this is what we generally think that, okay, now that residents are people who got trained to them, they also try to inculcate the qualities. But if some staff, by example, I'm not blaming the staff, but say for example, didn't do all that, but he's very good at the work, but he didn't have a good communication, but we think that that is also okay. So we initially thought that skills and non-technical skills are through osmosis, just by observing. So it's not so, but The same thing can be done through a patient simulation. This is in situ simulation, where you can see the we can put a microphones, or we can create a OT environment. It really looks like you are operating. The surgeons are there, the people are blood mobs are there, everything is available, and you have the anesthesia machine which are working, and we have ECMO. Anything can be done and simulated, and we can create a scenario, and we can come to know how a crisis is generated, how they respond as a team, and how you respond as a anesthetist. So this is where we started. We took it from the aviation. So I think Vinayak told properly about this crisis readiness management, the topics. So very important thing when a crisis happens, what are the things we should know? The first is know the environment. So where we are working, what is available, what is not available. Then anticipate and plan, call for help early, establish leadership and followership with appropriate assertiveness, distribute the workload. That is very important. That is very much appreciated also. They did a study on this. This is called as 10 seconds for 10 minutes concept. See, for example, suddenly when you're going through a crisis and everything is in chaos, you don't know what to do. So they tell that you just pause everybody, or you just take a pause of 10 seconds. In that 10 seconds, you rethink why everything is going wrong, why nothing is going right. Okay, and in that 10 seconds, you have to relocate the workload. Like, so for example, everything you are doing, suddenly you think that you are not able to manage. You give some things to the people who has come. So tell some things to the nurse, something to the other anesthetist, and within 10 seconds, you get a pause and you try to do better, and then you continue the crisis. So this is what they told about 10 seconds for 10-minute concept. But initially it looks very awkward, because you all think that every second counts. Where are the 10 seconds? So, but overall, if you practice it well, they told that 10 second for 10-minute concept has done a huge difference than other things. Then communication, then available information. This becomes very familiar. You have gone to some other OT or somewhere else. You are not posted in that OT and suddenly went into some other OT because some anesthetist was not there and you don't know about the patient. So that becomes a difficult thing, and it arises as a crisis. And reevaluate repeatedly. That is very important. Good teamwork and attention and prioritize things. So just to give an idea, like what are the crises we can create, what are the crises we generally get it when we do an anesthetist, and all these crises can be simulated and we can learn through. I know, because one of the things many people, we never come across malignant hyperthermia. So but the same malignant hyperthermia, I can create a crisis in a patient, normal patient. So for example, I can create a crisis of a bronchospasm in a normal AS1 patient. So we had recently a patient where we were given spinal, and at the end of 2 hours, when it was going to wear off, patient had a brady. So it's not explained. So any crisis can be created. So simple things like preoperative. We generally don't give too much importance to pre-op crisis. So compromised airway. The patient has come with a respiratory distress, and suddenly something like stroke, as we told, like patient is having a seizures. Like the trauma patient has come in the preoperative or in the casualty only is hypertension. So what you do, and the patient is posted for emergency laparotomy. So that crisis you want to do, like how good you can do, whether you did a first or not to know the patient, other things can be done. So intraoperatively, we can do n number of crises, but generally anything can be simulated. Simple things like anaphylaxis to local anesthetic systemic toxicity, as simple as not giving importance to the IV line. One case we simulated where the patient IV line was blocked, so they never paid attention to the IV line. And one patient, they connected the tubings and they didn't turn on the three-way stopcock. So small things which debriefing things can be done in the bigger crisis. Okay. Patient was spontaneously breathing, but he had a difficulty intubation. And when we gave a handover, the patient was breathing and the saturations are maintaining, and that is given from the emergency to the OT. And they thought that when they were giving a handover, they told tube is in situ. We never thought that tube can be esophageal intubation also. So suddenly we gave, because saturation was maintaining, because it was coming as spontaneous breathing, he didn't check in during crisis, because patient also had an hypotension or other things to think upon. Patient ended up in a desaturation. So it was because of esophageal intubation. So this is how the crisis works. So we can simulate so many things at a time and think of getting the answers in the debriefing time. So as a single person, we are not used to see everything daily basis. So really the simulation helps how we can conglomerate all those things like post-operative crisis. I will not go in detail about this. So really it's CRM helpful. So definitely it has improved so much of teamwork, no flow, everything, time, everything it has reduced. So we always know that this causes learning. I don't go in detail that. If you have a good simulation and if you have a good debriefing techniques, the cycle, that's what we have, a learning cycle can be done very well. So reflective observation, abstract concept, understanding what is the root cause, active experimentation, and a concrete experience. So when we do a CRM crisis or when you're doing, all these things should be included. Now people will be telling about what is ecological validity. That means you are doing simulation so much. Does really simulation helps the patient or does it really has done any outcome? So they have come to the studies on this also. They told that there is a validity of simulation. This is what they did. See, task analysis they did on simulator and they did on the operating room. Almost they got a similar values. So both were same, almost in little bit of difference. So definitely there is ecological validity of simulation also. We all know what are the benefits. It's a safety, patient safety, time control. Yeah, definitely reproducibility is there. Recording we can do and relearn on that. Very good for the rare events and error learning without harming the patient. Next, we all know that what are the, because of Meghna madam, you are in charge, she's certified simulation expert. Like that, we have so many certifications available. So if anybody interested, anesthetist, they can undergo the instructor certification and they become a qualified instructorship. With so many anesthesia pieces coming out, so this becomes an opportunity for the anesthetist also. Like they can think of being a simulator expert. We worked with one of our pediatric anesthetists, famous, I think Meenakshi sir will be knowing that Muraro. He practiced pediatric anesthesia till the age of 60, and I think now then he took over the simulation. So now he is an freelance simulation expert. So we can take up that. Then program accreditation is very important. Like we can insert qualification. We can have SSM, SSH. These are all the centers where so much of programs are there. Then in America, we have American Board of Anesthesiology Maintenance Certification itself. In the simulation requirement, they have included as a curriculum. So how much duration of things should be done, mannequin-based content, everything it is done as a simulation requirement. So what is the future? So technology evolution is there. VR and AR systems we have to integrate. Then we have a long training we have to do. Then system integration is very important. When we learn through simulation, wider adoption we have to do, becoming standard in initial and recurrent training. So what are the still emerging technologies we have? Artificial intelligence, we have hybrid approaches, mobile technology, and virtual reality. We can integrate and we can still go ahead with the simulation. Vision for the future. This is a career-long integration and anesthetist. So clinical personnel teams and systems undergo periodic systematic simulations activities. So entire career. So it's like inspired by our aviation. So this comprehensive approach, the various simulation modalities for diverse purposes. So the future is now. We are it. Okay, simulation is no longer a question. Okay, so we can include in our path and we can get a good training. This is our simulators. We have our centers, dedicated center in Yenepoya. Thank you. I will be able to take the questions.
Thank you, all the faculty. Dr. Thippesway can stop screen sharing. You can stop sharing the screen. Thank you. So we are very happy because the Yenepoya faculty have extensively dealt with simulation. We have even 5 minutes past our scheduled target to close the session. But see, as it is a new one, the questions will be very less because they would not have seen what is a simulation. So I am very happy. Even in 2015, I started a simulation lab. That is an advantage to be an administrator. So I request all the anesthesiologists to take up administration, because he has also mentioned Dr. Ravi Shankar and Dr. Hemant. Actually, when I was a medical college dean in government Thiruvarur Medical College, nearby is Pondicherry. It is only 80 kilometers. So I travel to Puthukkottai to see what is a simulation lab. So I have seen a fantastic simulation lab in Mahatma Gandhi Medical College. Again, thanks to the visionary Dr. Ravi Shankar, because he was the administrator at that time. So by copying that, I have established a simulation lab in Thiruvarur, and we have arranged a simulation workshop for all the postgraduates across the state at that time. Even first time, Thiruvarur is a very remote place. But even from Chennai, because Chennai is the headquarters, people travel to Thiruvarur to see. And even you are saying that PPH simulation, everything, we had it in 2015, because I attached with a Lardal mannequin, and one Princey is a nurse. She is a PhD in that. I have to acknowledge Mr. Parthiban from Lardal mannequin. So, and another one, Jay Ganesh, is a superior. So they have arranged, and this Princey is a wonderful nurse who can simulate, because at the moment she is having a cuff and a bladder and a insufflator. So at any point of time, she will make the uterus contract. At any point of time, she will make the uterus relax. And it was a wonderful experience. People crowded at that postpartum hemorrhage. Physicians are very happy. And actually, OG department won the first prize. We have arranged all the mannequins at that time. But I purchased this again, CPR, airway, because we are an anesthetist. That is advantage of an administrator. But extra, I had that intramuscular needle trainer, intravenous trainer, because all these basic training equipments I had. And even you are talking about ants. Even some 7 years back, I was requested by Kerala State to talk on non-technical skills for anesthesiologist. So these are all the good things. So I'm happy that I could do something as an administrator. And again, when I was transferred to Theni, I was transferred to Puthukkottai, everywhere, the CPR mannequin and the airway mannequin and the central venous mannequin are there. All the three compulsory everywhere. So I'm very happy wherever I worked, these three will be there. And intra-arterial BP monitor and ETCO2 and ultrasound and CM for the anesthesia department. So I'm comfortable the way in which you are saying that I have done. And today, you should feel happy about one thing. Dr. Hina Chanwal from Ahmedabad, Gujarat, she is seeing this program and she has sent me the screenshot also. And she said it is a good program and a need of the hour. And I want to mention Dr. Hina Chanwal is a governing council member in Indian Society of Anesthesiologists. So I think she will take it forward with a suggestion that ISA can do something with that. And incidentally, I am also in the governing council. So let us hope for something bright because of you. And now there are so many questions. So I request the people to answer that. See, actually, some questions are asked by me for clarity, because the people are beginners. So they want to know, they may not be asking questions, but for them, I'm asking the questions on behalf of them. So now we can have it as a rapid fire round, as we are having only 15 minutes to close. Before 8, we have to close. So anybody can answer. So what is the difference in low fidelity and high fidelity stimulators?
I think I'll answer that, sir, since I dealt with it. So
Yeah.
low fidelity basically means how well it can replicate the real life scenario that we have. So low fidelity is your task trainers, like your IV arms, your airway. It is only training you on that basic skill set. Or your airway head will teach you about intubation, your IV arm, your IV cannulation. If it is a this one ultrasound guided epidural block or spinal block set, it is only that basic skill set. So it's only your psychomotor skill set that you are gaining through your low fidelity simulators. While in high fidelity, it is really immersing you in a real life scenario. You have the mannequins which are able to replicate what a real patient does. These mannequins are able to replicate the pulses, the voices, the different types of murmurs, like Sir said. They have voices, they have blinking responses, pupillary responses. So it again aids to incorporate not just your basic skills, but application of your clinical knowledge, as well as how well you manage in a crisis, how well a team works together, because your mega codes and all can only be run with your high fidelity simulators. So there will be incorporation of non-technical as well as technical in high fidelity, but low fidelity is just your technical each skills can be trained.
Yumna, you are really a high fidelity simulator because I think, see, a teacher will be happy when their student performs better. Only two areas where people will be happy if they stand on our shoulders. One is our son or daughter, second is our student. And I think this Yumna has the great credit. I think out of all the postgraduates I have seen for these 47 weeks, I have to say, because the authority she is speaking as if she is Dr. Meghna Mukund, and she is very well experienced, and her elaboration is, she is quite confident what it is. That means she is having a first-hand experience, the way in which she moves her eyes, because I am seeing that even during the other speak, it is wandering here and there, and she has the clarity of that speech. Dr. Yumna, we request you to bring more talents in your future also, because you will be a very good teacher. I am seeing this horse will win the race. Thank you. And now Dr. Yashoda has mentioned, thank you all the speakers. Good information. Looking forward to learn more about simulation. So you have kindled interest. Now the next question will be, how many people you need to man a simulation lab? I mean, workers, I'm asking. Doctor, I think Dr. Thippesway can answer that. Unmute yourself. Dr. Thippesway.
Unmuted, sir. Okay. Audible?
Yes, tell me. How many?
Yeah, in our simulation, we have two. I'm telling about, I'll start from my simulation lab, then it will be easier. So, in our simulation lab, apart from the in charge, like Dr. Meghna Mukund and Dr. Ashwin, two are the in charge faculties who look after, who integrate with the different departments to run the scenario or to run the simulation. And we, inside the simulation, we have two main engineers who have done the engineering degree, and then they assist in the this simulation, and one or two will be housekeeping, and one as an assistant, like a group C worker, where for the clerical work. So at least we require minimum of 5 people, different cadres, to run one simulation lab full completely. And it actually depends upon like how much you have, because our simulation lab is a huge one. Like we have so many things to cover, so we have more personnel. And each department, we have allocated specific people who are all interested in simulation to come and get trained in simulation, and they can go and do a simulation as and when they intend or they wish.
Thanks. So, what about these 5 people's total salary structure? It is, I am asking you only a rough estimate. Whether you know, you can answer, or else you can skip this question, because this is for the many HODs will be.
So for us, actually, because we were interested, it is a shared additional responsibility for us. So if
I'm not talking about doctors. For doctors, always it is additional responsibility. They will not work for remuneration. So I want that paramedical people, how much you are paying?
So that is, I don't have.
You are not aware. That is nice. That is always happens in mainly private medical colleges. And now I want to ask you one question: whether you need a technocrat or anesthesiologist to operate computer-aided mannequins, because I have seen in Puthukkottai, they found it very difficult, because if it is a large tongue, if the epiglottis is not visible, everything should be manipulated in the computer. So whether a doctor is doing in your setup, or the biomedical engineer is doing that.
Sir, actually, the simulation run or the program scenarios, what we tell, the skeleton of the scenario is completely done by the anesthetist, but the help is taken to run the scenario by the technocrats, what they are there. Because the entirely how the when you run a scenario, I think sir you will be knowing like how it transitions happens. So for example, what is my initial thing and what will be my end of this transition, so that everything is planned by the anesthetist. So we need
Yeah,
not be
in a nutshell,
technocrat to
for
learn
the
that.
benefit of 1 minute, Dr. Thippesway, for the benefit of audience, I'm asking a straight question. This means instructions will be from the anesthetist. That is, you make it as a big ton. It will be done by the technocrat. It is that way.
Correct. So
Ah.
no, instructions and the planning is done by anesthetist or the program, whoever the
Now I'm
faculty.
asking
And
straight
the day
operation.
before the preparation, straight operation is between the two, sir. Anesthetist will be running the background, as we know, and the instructors only come and help you with the other works. The main instruction is by the anesthetist only.
No,
So the main
again, I think that it needs some clarity. The thing is, mental workup is done by the anesthetist compulsory because the technocrat cannot do that. So it is
Yes, sir.
automatically, it is granted, it is by the anesthetist. I'm asking who will operate the computer keyboard to make the tongue big, to make the epiglottis not
That is
visible.
anesthetist only, sir.
So
In our
again,
center,
it is done by the doctor.
yes, sir. Doctor only done because we run as a team and we all got trained in that, sir, initially. So
Oh.
that's like we know it, so we do it.
Then you need additional remuneration, right? The next question: how often you change the mannequins? Because
This is
the
mainly
episiotomy suture or suture trainer, they will repeatedly they will be pricking it. Na? So how often you have to change the mannequins?
If it
so
is,
this
sir, if
depends
it
on the
is,
mannequins. What?
I
Yeah,
think Dr.
Vinayak, sir.
Vinayak can answer.
yes, it depends upon if it is like, for example, which we use it for our BLS courses, the mannequins which we use for BLS courses. For that, we use disposable disposable filters that are available for mask ventilation. So, for example, single person rescuer, we use those disposable ones which come. So every person takes it and they have to retain it till the end of the BLS course. So suture, I'm not very sure how, I mean, surgical suturing, I'm not very sure. But I think as far as I remember, about 3 uses, it stays intact. And after that, they seem to have
No,
problems.
many usages it stays. Many uses
Yes.
it stays. This prick because it is a rubber, but I want to know at any point of time it is going to be damaged only. So in other words, the next question will be how you will meet the skill lab expenses. How you are doing it in your lab?
In the main thing, sir, one is our ACLS BLS is also associated with the skill lab, one thing. Second thing, we run the courses with the fees. Say, for example, if anybody wants to get done through simulation thing, they can come and do. Third thing is we run many workshops through simulation as an integral part. So for example, for the nurses, we every year for the nursing students, we have end postings like thing where we'll teach all the skills. So we try to give a little bit of, we keep a little bit of fees so that we at least we can able to maintain the simulations things.
Again,
But
for the benefit of government medical colleges, I say, because in one private medical college I have seen, whoever gets admitted in the college, 6,000 rupees fees is to be paid. Whether it is MBBS or MS Anatomy or MD Anesthesia, MS General Surgery, whoever it is, 6,000 rupees only for skill lab. It will be coming in that bill 6,000. So they maintain that way. But when I established a lab, government cannot collect the fees like this without any government order. So what I did anyway, for some another one, if you give free of cost, the students may not be interested that much. So I formed a students union from the hostel, and to enter the skill lab, they have to pay 50 rupees. Even that 50 rupees, it will be managed by students only. Because we should not poke our nose in that. Sometimes I'll retaliate. It is, but I don't know what is happening today. So government medical colleges should be careful with that. And Dr. Thippesway, in your lab, how much it costed you for establishing that skill lab? That means it is in crores or
yes,
it is
sir,
in lakhs?
Ours is high fidelity, sir. It is in crores only, sir. I think roughly, I think above 5 CR. That's what they
That is
told.
good because even in Puducherry it has costed 6 crores. So what we want to convey, a high fidelity lab will cost 5 crores. And that low fidelity, as Yumna pointed out, it is only a task trainer which I have, it will come to 20 lakhs. So if they are ready to spend 20 lakhs, all the necessary task trainers will be there. And again, I want to ask you, please elaborate on debriefing because it is a university question, MD and DIP&B. So how debriefing is done? You please explain that. So that will be the last question for the discussion.
Vinayak, you want to take on that?
Yes. So debriefing, basically there are different techniques. Basically, what is debriefing? Debriefing is to reflect upon what went right during the simulation and what are the things that can be improved upon. Here, we don't try to traumatize the students saying that, or scolding the students and things like that, saying that this didn't work out, you didn't do this and that. We just try to get out the right answers so that they should be aware of what went right during the simulation. But there are different techniques like Delta Plus and things like that. What also helps during debriefing is having some form of checklist, and the facilitator should have designed this checklist so that you don't miss out any points during the debriefing. So this becomes very important.
Thank you, because this debriefing and crisis management, they are the university questions which I have seen frequently. So that is an idea of me asking this question. Now I should congratulate all the speakers because they are having a first-hand. Tell me.
One
Tell
small
me,
thing.
Dr. Thippesway.
Yes, sir. The newer Miller, which we have a 10th edition coming, they have taken out simulation, also the very lesser information for the sake of PGs who are reading. So if you go for the older edition, something like an 8th edition, that has got this debriefing, and 9th edition, debriefing and the simulation are very well explained, sir. That maybe because they started with the newer editions, they have reduced it very much. That actually simulation has also, they have reduced the content.
But these Millers, every postgraduate will have it in their mobile phone and they are not reading it in library or anything. And I cannot recommend Miller because they are not going to read. They are reading only ChatGPT and this Gemini and a notebook LLM. Yumna will be having any one of the three or all the three. So that is the order of the day. So we cannot say that you won't read anyway. That is a good point. A new thing simulation coming out means they want to increase the artificial intelligence more in that. And really simulation is going to, as you pointed out, when we learned that is different. To see one mid-diastolic murmur, the patient will be irritated. If I say one mid-diastolic murmur is there, then 100 people will be there. Night, afternoon. Nowadays, it is not a problem. They will switch on the thing and they will not consider murmur also. They will straight away do echocardiography. They will say it is mitral stenosis. So situations are changing. So definitely the simulation will take over. And I thank Dr. Yumna, the wonderful would-be professor. And I wish her a good life and a career ahead. She has proved. And Dr. Vinayak and Thippesway can be happy to have a postgraduate like this. It is because of your training. And another one, the best part, she is from Kerala, but absolutely there is no Kerala tone when she speaks because they will be having a typical format. But it is also not there, so she has to come up. And I know Dr. Vinayak and Thippesway for a longer time. There, I know I'm as an assistant professor and professors. So it is very good to see them in the simulation. I will be getting the congratulatory messages soon. So it is a wonderful day, and you have simulated how exactly the simulation lab looks like with all the points. So I should congratulate all the three. And because of the simulation, Dr. Meghna Madam is flying high. Not because of the lab, she's really flying high, probably at a 30,000 feet altitude, she may be flying. So I like your simulation lab also should fly sky high. Now I request Rimpa Clearnut to close the session with the concluding remarks.
Thank you,
And
sir.
we thank you, sir. On team Vinayak, Yumna, and on behalf of the entire Yenepoya Medical College, we thank Meenakshi sir really for us giving the opportunity to go national webinar, sir. Thank you very much, sir.
You
Very
people have obliged me because the first 42 webinars, it was conducted according to their wish. Suddenly, I thought I'm going to close it on 52nd webinar. It is January 14th. So I started deciding the topics which are not covered. So next time it is going to be physics. Next time CPCR, onco anesthesia. What are all the topics not covered? I started dictating, but you people obliged and you have done it very well. Really, it is sky high. So thank you, Rimpa.
So, thank you so much, everyone, for joining this session. Clanet is really glad to have all these brilliant people together. So, with all your permission, I'm closing the session for today and looking forward to hosting you again. Thank you so much, everyone.
Thank you. It is exactly 8. Thank you.